the side effect of sexual dysfunction. It's really better to break that down because there are distinct symptoms that are comprised by the more general term sexual dysfunction. And also, I'll say that sexual dysfunction is often impacts men very differently than women. There are many factors that come into play, including a person's reproductive age, what stage of life they're in. For example, loss of libido due to a medication like Prozac or Zoloft that increases serotonin occurs across the board, but it's the most severe and the most refractory to treatment in a postmenopausal woman as opposed to a teenage boy. So you're going to see vast differences based on epidemiology alone, based on demographic information alone. So in this first video, I want to talk about anorgasmia. Anorgasmia is the inability to climax, or a very delayed climax. It takes much longer, a lot more effort, and often patients will also report that when they finally do achieve orgasm, it's not as satisfying. It's due to the occupancy of serotonin at a very specific receptor subtype, the 5-HT1A subtype. And at the level of the spinal cord, it blocks that spinal reflex that's necessary to achieve orgasm. It's not always a problem. As a matter of fact, one of the most effective and simplest treatments for premature ejaculation in men would be 10 to 20 milligrams of Paxil. Paxil is the most potent SSRI in vitro. It blocks the reuptake of serotonin most potently, milligram per milligram, compared to the other SSRIs. And that's associated with also more severe sexual dysfunction. But very low doses can actually treat a condition like premature ejaculation. This is one of the side effects that's the easiest to address without having to change the offending medication, and it's always due to serotonin. So not just SSRIs, but SNRIs, and really any serotonergic medication, any medication that increases serotonin and the actions of serotonin can cause anorgasmia. But because it is a very specific receptor subtype, we can add a medication that will block that receptor and thereby reverse the anorgasmia. It's not as straightforward as that. There are no guarantees. Sometimes patients don't respond to those antidotes, but there are specific medications available without otherwise having to change our main antidepressant or anxiolytic agent. It's a dose-dependent side effect, so another option would be to lower the dosage of the medication that's causing the problem, because there is a threshold. And so it just has to do with how much serotonin, extra serotonin, is at this particular receptor subtype in places in the body where we don't want it, and in this case, the spinal cord. So one strategy could be to lower the dosage, or change the medication. But if a patient is taking a serotonergic antidepressants because that they need a serotonergic antidepressant, and so it would be a mistake, for example, to switch somebody with a lot of anxiety and irritability and tearfulness from Prozac to Wellbutrin for sexual dysfunction, because Wellbutrin doesn't treat the same symptoms that the Prozac does. So switching the medication entirely is usually the last option. Lowering the dosage is always a possibility, as long as we don't lose efficacy and as long as people don't then experience a relapse of their symptoms. Unfortunately, it's one of those side effects that could be indefinite. Most side effects people do develop tolerance to, and they get better over time. Some take typically weeks and weeks, but this is unfortunately a side effect that for some individuals is indefinite, that as long as they're taking that dosage of that particular medication the way that they're taking it, they will always experience anorgasmia. It's never going to get significantly better. And so we have to either lower the dosage, change the medication, or more often, my number one solution is to add a medication to block that receptor. And there are several options. Buspirone is one but it works maybe. I couldn't give an accurate percentage, but it either works or it doesn't work. I just typically tell patients half of the people that take it will have a favorable response. And again, that's also dose dependent because you're competing. Buspirone is competing with serotonin at that receptor. So it has to do with the level of that particular medication, how well it's absorbed and how it gets to where it needs to be, and then how it competes with serotonin. Buspirone is actually a partial agonist at that receptor subtype. It's not an antagonist. So it doesn't block the receptor so much as occupies it and then activates it, but not as much as serotonin would activate it. And it's activation of that receptor that's causing the difficulty, the deficit. And so I think that that's probably why for some people adding buspirone doesn't help with climaxing, and for other people it does, because you're still activating that receptor. There are antagonists such as the antihistamine cyproheptadine, also mirtazapine, Remeron, which is an antidepressant unto itself that is not an SSRI. It has several unique mechanisms of action that increases both serotonin and norepinephrine. Those tend to be more effective because we're actually not just competing with serotonin, but when the medication occupies that receptor is blocked and it's not activated by all the extra serotonin that we have because of the treatment. The problem with those agents, those two specifically, is that they cause weight gain, and almost everybody who takes them, and that weight gain can be very significant, and most people don't want weight gain. And if you're trying to lose weight, it can make it virtually impossible to lose weight. And so that does limit the usefulness of that medication. Medications like Wellbutrin and Strattera that don't significantly increase serotonin at all do not cause this side effect. But again, just because two medications are classified as antidepressants doesn't mean that they are both equally indicated in any given syndrome. It depends on the target symptoms. And serotonin, increasing the level of serotonin, addresses completely different target symptoms than increasing norepinephrine and dopamine and other neurotransmitters. So often changing the medication or switching to a different class it takes a long time. You have to cross taper and you might lose efficacy. The easier thing to do is to prescribe an antidote. The other thing that I always tell patients is that timing is very important. In as much as it is a dose-dependent phenomenon, and presumably the patient is at steady state, so they're taking their medication once a day and they have fairly stable levels of the medication at all times due to the medication half-life. There are medications that you have to take 2 times a day or more because of the half-life in order to maintain that steady state, in order to prevent the levels in the blood from waxing and waning. But that's in terms of efficacy. In terms of side effects, it can matter a great deal whether you just took your dose or whether you took your dose that morning, as far as this particular side effect. And so for a lot of patients, if they take their medication and then an hour later they engage in sexual activity, they may be completely anorgasmic. Whereas if they move the medication further away from their attempt at climaxing, they'll be much more successful. And so if a person is typically sexually active in the evenings, then often I'll recommend moving the medication and taking it at bedtime before sleeping. And that gives the longest period of time, and levels will be, even though you're at steady state, the level of that medication in your system will be at its nadir, and you'll be more likely be able to achieve orgasm, whether you're also co-administering an antidote or not. And so timing is very important.